Hey guys, I know for the respiratory system I did airway adjuncts for respiratory distress and oral tracheal intubation. Miss Fowler had posted maybe wanting to see some of the tools I had talked about. I'm a paramedic here in Davie County, and every so often I get to do something really cool is do oral tracheal intubation. So here I've got my Mr. Mannequin, and we've got our bag valve mask with the attached mask piece here. And of course, before you do oral tracheal intubation, you have to make sure that your patient is fully oxygenated. So you would take your mask and adhere it to the face, and you would ventilate your patient. Now, Mr. Man here doesn't get a good seal, so you don't see the chest or the lungs inflate with the BVM, but he's still in respiratory distress. Here we have our ET tube, which stands for endotracheal tube. We have an old airway adjunct device called the combi tube, being that it has dual ports, so no matter which airway it goes down, whether it goes down the trachea or if it goes down the esophagus, one way or another, you can still ventilate the patient. But we've done away with these, and now we have the Kings. These come in pretty much universal sizes, and they're height-based. So we have like a purple, a red. We have a couple other colors that, like I said, are height-based. Most of the one that we use is the number 4 King, and it is color-coded by the red top, and it is called it's a blind airway insertion device. It's called a blind airway insertion device because you're not actually looking down into the oral pharynx and trying to find the vocal cords in order to place a tube to breathe for your patient. This, you simply just slide in through the mouth, go posterior of the tongue, and whether it goes into the trachea or the esophagus, which most likely is going to go into the esophagus, you can still ventilate your patient. Once you have it entered, you blow up both of these balloons here. They inflate, they close off, and allow ventilation through the holes here at the end to ventilate your patient. This King, not really my favorite. It has a hole opening, the end is open rather than the balloon completely covers the end. So the bad part about this type of King, it's supposed to be for suction purposes, but really it just allows for more air to enter the stomach, and it is a nice vomit spout right to your face when you're trying to bag them. So I really don't like this style. The ones we have on the truck are the better ones, and the bulb actually covers the end. You can't suction through it, but that's okay. We also have airway adjuncts. We have what we call an MPA, the nasopharyngeal airway, excuse me. This goes into the nose, into one of the two nostrils, usually the right one because it tends to be a little larger. And it's used in adjunct with the BVM and the mask. You also have the OPA, which is the oral pharyngeal airway. This is inserted into the mouth, and it goes posterior to the tongue, and it just holds the tongue away from the epiglottis, and so you can actually ventilate your patient just a little bit easier. Again, used in adjunct with the BVM, the mask. You can actually use the MPA and the OPA both at the same time. You can actually use two, being that you have two nostrils. You can use two MPAs and an OPA in adjunct with the BVM until you can do further advanced airway treatment. But of course, my favorite, being a medic, is being able to do the endotracheal intubation. You have to use the laryngoscope blade. Of course, this is the blade, and this is our handle. And we have different size blades that we use, but this one is one of my favorites. It's a Mac 4. And I haven't had any trouble intubating anybody with a Mac 4, but everybody has their preference. So in order to do so, we'll say that our patient is in respiratory distress, and we're going to fully oxygenate our patient and make sure we can try to get our sats up. the SATs are not working too well, so we're just going to try to hyperventilate for just a minute. Then we've got all of our tubes here, all of our tools ready. After we've, of course, someone would still be bagging my patient for them. We wouldn't just leave them not being able to breathe at this point. If they are unresponsive already and don't have a gag reflex, then we do the oral tracheal intubation without medication assist. If they do have a gag reflex and their airway is not patent and they're not able to maintain their own airway, then we assist them by giving medications such as etomidate and succinylcholine, which are sedatives and paralytics, as to be able to intubate and breathe for them. And at that point, their respiratory drive is completely in your hands. So you have to be very careful of that, because you can kill somebody with what we call RSI, which is rapid sequence intubation. That's what it stands for, but it's drug-assisted ventilation. So anyways, you insert the blade into the mouth here, and you lift up on the tongue, and you're looking for the vocal cords. Now my Mr. Man here is a little difficult to do by yourself, so just bear with me. It's really not this hard to do on a real person, not in most cases, unless you've got trauma involved or an abnormal airway. This mannequin, Mr. Bob here, he's been intubated so many times that his oral pharynx is actually a little bit torn and distorted, as though he were a traumatic patient. So, poor guy. We'll see if we can get this in without adding lubrication to the tube, because then it just gets really messy. You take out the stylet, which is in the middle of the tube, which helps guide the tube into the trachea through the vocal cords. And I don't know if you can see, but where he is a hard intubation, when I ventilate, the stomach is what moves. So therefore, it tells me that I've intubated into his esophagus. Not good. He's still not going to be able to breathe if he's intubated into his esophagus, right? So, at which point, you just deflate the tube, and you attempt again. This would be a lot easier if I had an assistant here. So, I'll put the stylet back in. Another thing I talked about on my post was a thing called the bougie. I was unable to find a spare one here in our training room to show you, but it is a neat tool to help with blind airway insertion device. And actually, probably Mr. Bob right here would be a prime candidate for using the bougie. One of the things you have to worry about when you're doing this oral tracheal intubation is not knocking the top teeth out. You can't rock back. You have to pull up. So most people are right-handed, and I am. So that's why the blade goes in your left hand, and you pull up. Let's try adding a little lubrication to this tube and see if it will pass this time. It's going to get kind of nasty. Ugh. So let's see here. Maybe we can make this work. Let's see here. Positioning of the head and neck is really important. And he really doesn't have a real sturdy neck. It's pretty much been demolished. So I'm not sure if I'm going to be able to get Mr. Bob here intubated. I might have to grab one of my other airway mannequins to show you guys. This is really not this hard to intubate, I promise. It's actually really cool. So bear with me one second.